but never mind. The next talk is by Cindy Neunert, one of our medical advisors and also one of the authors of many articles that we published in the Platelet Letter from America. And Cindy will be talking about the dilemma of the refractory or relapsed patients. Cindy.
Thank you, Mervyn and Adrian. It's always fun to come here and get to share what is going on across the pond. So this is my live version of the American perspective. So what does it mean to have refractory or relapsed ITP? And I think this is a little bit more of a philosophical journey for this talk, but we do have a definition. So some of you may be familiar with this definition. It came out of a paper published in 2009 that says, the definition of refractory ITP is failure to achieve a response or loss after splenectomy, the need for ongoing treatments due to risk of bleeding. And this can also mean we can't use on-demand or adjuvant therapy. And then it has to be confirmed primary ITP. So let's walk through these. The first is that this has to follow splenectomy. And I don't think I need to, the stage has been set really well for me to say that a definition that relies on something that was first done back in 1916 might not remain an appropriate modern definition. We know from nationwide studies, as we've already been shown, that splenectomy rates are declining. We just saw this with your own registry here. It's also highly dependent on patient values, preferences, perhaps contraindications, may not be applicable, particularly in children. And we also know that there are some patients that have an accessory spleen, so a spleen tissue that gets left behind, and that may make them not responsive. And then, as just pointed out, guidelines and consensus documents are really recommending that we defer splenectomy for at least a year, if not even longer if we can. So arguably having this be part of a definition of refractory is really maybe no longer appropriate. So what about the next component? So the need for treatment. And this is the need for on-demand or adjuvant therapy alone does not qualify one as refractory. And it's a need for treatment that's really based pretty much on minimizing bleeding and significant bleeding. This does start to move us appropriately away from just the platelet count alone. So it's not just based on having a response in our platelet count, but it does start to account for some other patient-related outcomes like bleeding. But we don't have a good definition of significant bleeding. So we're relying on something that involves a term or a word that we really still don't have a good definition for. And we don't really have a lot of validated scores to use in the clinical setting for this purpose. We also know that very few patients will have clinically significant bleeding events. These are fortunately rare events. And so is it appropriate to have that term as part of a definition? And it still doesn't fully account for everything else that goes into our decision-making in the management of ITP, including health-related quality of life and fatigue. And what about patients who are responsive but not with a durable response, or those who go on what I call the ITP roller coaster of having their platelet counts go up and go down and go up and go down? And what does that journey look like, and how do we account for that? So lastly, this definition is really reliant upon confirming primary ITP. So let's spend a few moments on how do we confirm this diagnosis. So this comes from the consensus document. You can see here that there's sort of a basic evaluation. Then maybe in the middle, we have this expanded column of things that might be done potentially in certain patients. And then over here, kind of unproven tests of certain benefit. But really, as we've already been shown in the earlier talk by Dr. Proven, we really have a limited initial screening panel. So how do we get at this true confirmed ITP and move through this? So next, I'll show you kind of two proposed algorithms of what this could look like. So this is one by Dr. Jim Bucell, who many of you also have heard speak or are familiar with. And it shows patients walking through an algorithm based on the treatment, the response, whether they become defined as refractory or not refractory based on having a response at each level. It indicates time points at which maybe we should do other tests. So here's our bone marrow, and then down here is really this expanded again with bone marrow, but it's not very specific. And it's not until we get all the way down here that we start to actually say this patient is refractory and may benefit from this very expanded panel of tests. Here's another similar algorithm that just again shows a patient walking through different phases of treatment and whether or not they have a response and being defined as refractory or not refractory. Again, with initial expanded evaluations and when they should occur in terms of a second line, and then again, third line. And third line here is really just genetic testing. But again, we have to work through a lot of steps before we end up down here labeled as a refractory patient. I think this matters, though. To me, when I reflect on this, where it really matters and where it really has impact is in how we think about patients clinically that are sitting before us, but also how we end up with labeling indications. So our words that we sort of maybe arbitrarily define end up in labeling indications. So here's FDA approvals in the United States. And this is for fostamatinib, we have romoplastin, we have AVA, L-thrombopeg, and you can see here, even the word chronic ends up in all of these. And it makes it extremely difficult to then use these therapies outside of this setting. And I think the word refractory is equally as important in terms of how we begin to think about treatments and patients and when to use things. Because there's power in our words. We need a word, we need a thought that removes reliance on disease duration to introduce treatments and therapies. I think we absolutely fundamentally have to move away from this. I think what we're really trying to do, if we think about this last component of the current definition, is to identify a group of patients that maybe have an alternative underlying diagnosis. But do we really want to wait until we get all the way down here after exposures to all these different therapies to begin to think about that? And reliance on these algorithms and this word refractory may be doing that. It may be delaying patients actually getting consideration for alternative diagnosis. I think we need to think about terms and words that actually assist us in our labeling indications, that actually assist us in getting medications for the patients who need them, when they need them, not just because they fall into a certain bucket of an arbitrarily defined term. I also think we need terms or words that help patients understand their disease and their treatment options in a positive way, not a negative way, not in a negative label as I'm refractory, or I have a chronic condition, or my ITP is particularly difficult. I think we need to move away from labels that actually don't really necessarily help patients either in their understanding and in what they can then begin to think about in terms of their medications and therapies and plans. So I told you I was here to talk about what's going on across the pond. So this is my chance to again talk about the ITP Consortium of North America. This is a pediatric group. It's 40 centers across the United States, Canada, and now Mexico that really represent a consortium, a research consortium, but also we work and we pair with PDSA and patient advocacy to work collectively. We had a really grateful family that actually provided us with funding to get together for a 2-day meeting. And the only caveat was that it had to be somewhere in Denver. And for any of you that have visited the United States, that's a lovely caveat because Denver is absolutely beautiful. And we actually moved it a little outside Denver. And we got away with meeting in Aspen, which is simply glorious. So none of us complained at all about the requirements for this meeting. And we chose a 2-day discussion of really getting into this word refractory. We think it's one of the words that hangs around, is ill-defined, and maybe we could do better if we really got into it and went into the weeds a little bit. Before the meeting, we identified 3 components that we thought were important. Timeline of the disease that we needed to talk about, what previously trialed medications, mechanisms, numbers. We had done some systematic reviews, pulling what others had looked at in terms of definitions. We did some surveys within our own group to understand where we maybe had consensus and where we didn't. And then we talked about platelet count and symptoms. So not just platelet count, but everything else that we know is important. And we underwent an iterative process over these 2 days in this lovely setting here. So it was very hard to work, but it was set up really well. We got breaks in the afternoon, so it was quite lovely. So again, with our considerations, when we talked about numbers and types of treatments, we really wanted to account for global diversity in treatments. We didn't want to have to label certain medications because we didn't know who has access to what medications. We didn't really feel that it was the medication itself that was most important. We also wanted to account for patient tolerability and patient preferences. And we think that that is really a key component of how shared decision-making plays in picking a treatment. And we wanted that to be reflected in whatever definitions we came up with. We wanted to account for the whole disease severity, again, accounting for all the different aspects. And then our goal in defining this population was, one, to really identify patients for novel therapies, combination therapy, or more upfront progression through therapies. We wanted to increase drug approval for our most affected patients. And then to better understand the biology, I think this is the other tricky part, right? If we start with a label that's very arbitrary and we put patients into buckets, we might put them in the wrong bucket. And then when we go to do the biology studies, we might actually miss the signal because we've already assigned patients, as opposed to letting patients group themselves based on similar characteristics and then looking. So sometimes terms can actually work against us a little bit, even in research. So here's sort of our current treatment algorithm. And I think the problem is, right, these are all so highly linked, newly diagnosed, first line, here's our options. Persistent and chronic, linked to second line, linked to these options. Down here, refractory, then we start to get into third line or combination, additional testing. We really have to move past, I think it's time to uncouple some of these. I think it's time to uncouple our disease description terms from how we think about treatments and how we might move a patient through a treatment algorithm. And this was really the outcome of this meeting after we talked, and we decided not to necessarily 100% throw out the word refractory, but we did feel we needed to polish it up a little bit, give it a little bit of an upcycling, so to speak. And we really almost did completely say this word is, we don't want this word anymore. It's a negative label. It's not helpful. It doesn't actually really tell us what we want to know. So this was what we came up with by the end. So we grouped things by timeline, not so much in terms of thinking about newly diagnosed or persistent and chronic, but in terms of how we use therapies. So we have these emergent therapies. Maybe those are our first line. We use them because we want that quick, rapid increase in the platelet count. We did think it was important to identify patients that have no response to those therapies, because those are the patients that, at least for me, if I know I can give you IVIG if you come in with a significant bleeding event, that actually is different to me than a patient that I know I don't have that as an option. And I might think about treatment differently. So we defined this first group as refractory to emergent therapy, was no platelet count response after treatment with all eligible emergent. And again, we threw in all eligible because we realize in certain places anti-D, for example, may not be an option. Some patients may have a contraindication to corticosteroids. So we were just trying to account for the fact that these are patients that when they bleed may not have an option for a prompt platelet count increase. And that is to us a signal of a patient that we should start to advance more quickly towards getting a stable platelet count with maintenance therapy. So then we moved on, and we really actually did throw out the word refractory here. We thought it really didn't matter. We thought that we could just talk about how we wanted to identify patients and help them. So for pediatric ITP patients who are platelet count non-responsive and continue to demonstrate high disease burden, and we thought that this was important to use the word disease burden, not necessarily bleeding symptoms, but collection of symptoms. despite treatment with multiple classes of disease-modifying therapies. So we said greater than 2 mechanisms. So somebody could fail romoplastin but respond to L-thrombopag. That would not make them failed the class of TPORAs. And I think that what we were trying to achieve with this was really identification of what might be the next best treatment. So if somebody fails T-cell driven therapy or B-cell driven therapy, that might be more important than the name of the drug that they failed, as really the mechanism. Where should we go next with this patient in terms of immune modulation? We also, again, coming back to this notion, they merit additional investigations to identify alternative etiologies of both immune and non-immune thrombocytopenia, and they warrant consideration for clinical trials and novel therapies. So really trying to advance patients quickly to get therapies, but avoiding labels that can sometimes put us really into a corner. So I think what we did was pretty nicely kind of gray out the duration of the disease. Maybe it doesn't matter. Maybe we don't need these terms anymore. We tried to focus on emergent therapies, not first line, but just emergent. That's how we're using them. Here they are, and we can be refractory to these therapies. Maybe we need to move quickly then to maintenance therapy. And maybe we can actually be responsive to maintenance therapies, but still refractory down here. Here's some of our maintenance therapies. If we're non-responsive with continued high disease burden, then we should start to look for different mechanisms, different etiologies of the platelet count being low. So here's the paper from 2009. It was by Francesco Rodiguero, and this is actually also under review. So I think we're working collectively as a whole. For this paper and this kind of revision, we're including representatives from patient groups as well as from labeling agencies, just to really make sure we achieve what we all want, which is to get better access to medications. So I'll just end with us. We did have a nice round of planking for the platelets, care of the Australian ITP group. We didn't declare a winner, but there were definitely some competitive souls in the group, go figure. But I'll just end there and would love to take some questions during the Q&A later. Thank you.
Thanks very much, Cindy. We're now going to go for a short break. If we can get back for 3:30, please, 25 minutes. Just if you can take the opportunity when you actually go out to have a break to do the interactive wall, the patients can do the interactive wall.